Welcome back to Health Policy Off Script. I am Matthew Hart from Longwoods. To quote our guest, "This is ridiculous that they can't access the care that they need in a timely way, and people have to do what people have to do." How does private healthcare work in Canada? What is its role, and does it have a place in the Canadian health system? Today, your hosts, Stephen Lewis and Dale McMurchy, have this ever-debated conversation with Colleen Flood from Queen's University in Ontario. To introduce our speaker and start the conversation, I'll hand it over to Stephen.
Today, I am thrilled that we have Colleen Flood. Colleen is the Dean of the Queen's University Law School. She was formerly the Director of the University of Ottawa Centre for Health Law, Policy and Ethics. She's a member of the Canadian Academy of Health Sciences, a Fellow of the Royal Society of Canada, and was the Scientific Director of the Institute for Health Services and Policy Research of the Canadian Institutes of Health Research, and they have even named a prize after her and her colleague Morris Bearer in honor of health policy achievements. So welcome, Colleen.
Wonderful to be here, Stephen. Thank you very much for asking me.
In Canadian healthcare, nothing excites the passions of people as the term public or private healthcare. The public part of Canadian healthcare is pretty well described. 70% of health spending, or about $280 billion. That 70% is pretty low by OECD standards. First off, Colleen, does this matter?
For sure. The public part of Canadian Medicare is very segmented or siloed. So the public part of Canadian Medicare are hospitals and doctors. So there we're very deep, right? 90-something percent, 95, 96% public. But for other parts of our healthcare system, particularly prescription drugs, but long-term care, home care, physio, everything else really, outside of the hospital walls and outside of what doctors do, fall into a much more of a mixed public and private world. For those parts of the healthcare system, we take much more of a US-style approach to financing. Always leads to a gap. There's always a gap of people who don't have insurance or are underinsured, and that is a continuing problem for us in the Canadian system. And it leads to high prices and high costs, which we see in prescription drugs, for example. So we pay some of the highest prices in the world. And as you well know, Stephen, that's kind of counterintuitive for a lot of people, right? They think if we're spending less publicly, that it's got to be better. We're saving money somehow, right?
Yes. Well, so you've touched on why this might matter. And one reason why it might matter is we have this thing called the Canada Health Act. And one of the principles is comprehensiveness. And if I dropped in here from Mars and I said, well, comprehensiveness, cool. That's right in the Canada Health Act. I'm going to get physio, dentistry, mental health counseling. That's going to be in, and it's not in. So is this a hollow, almost cynical part of the Canada Health Act now? Is this a source of the problem in your view? Like, why doesn't it have more teeth?
Well, teeth are one thing, and then the size of your mouth is the other. So the way that the Canada Health Act was set up, first created in the 60s and solidified through into 1984 when McMurchy brought it through, was that it was based around initial desire to expand hospital insurance first to all Canadians, and then building on that incrementally, like let's take this on and build it on to physicians. And then, I think the hope was that eventually it would be expanded. It got, set in stone in 1984 as applying only to hospital and physician services. There's some stuff about transfer payments for other things, but it doesn't have any real statements around comprehensiveness to include, for example, as you mentioned, dentistry or prescription drugs. But we have been, I think, so scared to touch it for fear that it would undermine even that, right? So I think there's just so much worry that opening up the Canada Health Act or even suggesting that that's a good idea would not result in expansion to other domains, but in fact would allow for further retrenchment and privatization of hospital and physician services. And certainly that's been the move that many groups have and individuals have tried to make. They've tried to take away that security as well. No one's really kicking in the door to expand to dentistry, prescription drugs, and so on.
The private insurance market is kind of a workaround to the comprehensiveness problem, right? But is this a hill anyone should even think of climbing, let alone dying on?
I think we should care. There are always people who are left out of the system. And, we've seen some moves recently, for example, at the federal level to try to expand insurance for people living with diabetes, for contraceptives and so on. Some very, very modest kind of attempts there. But those folks, they do fall through the gaps. So I do think it really matters. And it also goes to the sustainability piece. So the sense that we can't afford the public part of Medicare that we do is in part because we're paying so much money for these other pieces, right? So we might not feel like we're paying that money because it comes to us through our private health insurance plans via our employer, but we do pay for it.
I can
Yeah.
tell you that for those of us that don't have any private insurance, you feel the sting. I want to come back to the Canada Health Act. Not that long ago, nurse practitioners and pharmacists were added to the definition of essential services.
Well, obviously you can expand the Canada Health Act, but they haven't expanded the definitions in the Canada Health Act in any real way. This is all through kind of bilateral agreements with provinces, correct?
Yeah.
So these kinds of things are workarounds to say, look, we want to do X or Y on home care or long-term care, or we want to, do different things, and we will enter into specific agreements with provinces, but not expansion of the Canada Health Act. Could we do that? Could we open it up and expand to different areas? Of course we could. The feds moved ahead, not because they really particularly wanted to, but because the NDP was holding their feet to the fire around dental care. And when you think about it, it's actually quite brilliant, really.
It's brilliant. It is also a conveniently good example of how to do it because dentistry is pretty distinct, right? I mean, when you don't have rehab or you can't get an OT visit for a frail elderly person, that's kind of should be part of primary care if you're talking comprehensiveness. But dentistry is kind of out there. But let me get you were touching on the federalism part. Provincial governments spend 40% plus of their budgets on healthcare. Is it just a non-starter to even think about making the system more comprehensive in the public sense? They say, look, there's a limit to what provinces can do here. And unless the feds put in massive amounts more money, it's not even a good idea, some would argue.
That is a difficult question when the trade-offs are things that are other social determinants of health, like education and housing and so on, right? That these things are all very important. However, like we come back to the sort of basic health economics of healthcare. And we know that if you keep having these sort of splintered public and private kind of arrangements, your public system, which actually picks up the most expensive folks, right? The elderly and those who are living with multiple comorbidities and the poorest of the poor, you're going to be paying the lion's share anyway. And the more that you let the prices get stoked up in the private sector, the higher the prices are that you're going to have to pay in the public system. So you put those two things together and you're not really helping yourself. Now, the prices part is the important part, right? So getting, better bargaining on the part of prices. And I would say, look, if prescription drugs were in properly in Ontario's healthcare system, then we would be having to be a bit tougher on the prices that we pay for other things, including physician services, which I know many of my physician friends will not love me to say that, and for other things too, for nurses, for pharmacists, and so on. But you would be making more rational decisions between, I hope, things as they actually equate with effective healthcare outcomes. So are you actually bringing value to the table to the public plan? And what will I pay you for that?
Right.
Right.
But they do
No,
what they do in other countries. I mean, instead of, as you mentioned, going all in near 100% on two things and then almost nothing on others, they smooth it out more. If they have some modest co-pays or
yeah.
whatever, it at least extends across the board. So they have a more rational distribution of services because now, once you say, well, I don't really need to see a doctor, but you better see a doctor because you don't have to pay for that. And if you want to go private for physio and all this other stuff, as Dale says, you feel it. You know, middle class people feel it. If you have to go 10 times to a physio, it's quickly $1,000.
So, I mean, how you draw the limit, different systems make different choices about that. But the kind of argument that is constantly made that, privatization is the solution to our problems there's just zero evidence.
But we're also having the creeping privatization on what's currently publicly funded. And I'm not sure that people can fully understand what the trade-offs are when that starts to happen and what is really happening on the ground when we have private payment. And you've touched on the increasing prices and that sort of thing. But what are some of the other things that we really need to be thinking about and understand with increased privatization?
So let me just back up and say, I think a bigger problem that we have in the Canadian system is that the public discourse around Medicare and public Medicare is such that it is so much our moon and stars, and from a government perspective, it's our moon and stars. And so there is not enough attention applied to the regulation and oversight of the private sector. So you see drift, right? You see family docs providing a lot of Botox and cosmetic
Yeah.
surgery and nurses and stuff doing this kind of work, or any kind of payment that sort of slips outside the current sort of rubric of regulation that is sort of protected in the public system.
So again, another principle of the Canada Health Act is accessibility. We know that 20% of adults, more or less, don't even have a regular source of primary care. And we see middle class people who believe in Medicare saying, I'm done. I will pay the $4,500 a year to sign up with a boutique primary care practice. Is this a thumb in the eye of the Canada Health Act right there?
It has been around for a while now. It's becoming more widespread as not just these concierge clinics, but people are trying to get around the limitations of primary care by buying online care, virtual care, Maple, and all those kinds of things.
Yes.
And I just want to say, first of all, no judgment. Anybody who needs to do this because they need to access primary care, of course. Right? This is ridiculous that they can't access the care they need in a timely way, and people have to do what they have to do. So it is a statement, it's an indictment of our public system. I don't think it's particularly an indictment of the Canada Health Act or public Medicare, but it is an indictment of our government and our governments and our leadership and lack of focus on health policy.
Is this just a failure of policy, or is it a failure of anticipating capacity?
We do have problems with access, but we also have problems with supply. So ensuring that we actually have, healthcare teams that are able to work in the kind of way that we want, or family doctors and so on, that are able to provide the services. So increasingly people are working less time, fewer days. From a systems perspective, it's not so great. So how do we think about that? Do we just need more of the units of supply because they're working less time? Do we renegotiate the deal in terms of what level of service they have to provide if they're part of the public system? Willingness of governments to do this. But as we've seen in Quebec, if you kind of go down that pathway, you can be really, really punished at the polls because the public, they don't understand health economics so much. And They believe their physicians who might say, well, it's not us, it's the government who are the bad guys here. And I'm not saying anyone's bad. It's just, the system of incentives and so on that we set up.
The private sector could probably do it better, could probably do it more efficiently, and Medicare may have been a good idea in 1962, but it's kind of we've proven that we can't really get it right. So let's try another option. Is that what's going on here?
Public Medicare is not as good as what we want, and we know that as we see growing inequality in society, so more rich and more poor and a widening gap between them, that trying to strike the middle ground in a public plan is harder and harder.
Just keen to hear what Colleen has to say about how we're going to fix it.
So let's move into this. So Colleen, let's start with the optimistic premise that if the public system were really as good as it could be, there wouldn't be that much interest in or demand for a private system. So those middle class people who are leaking to the private sector, if we did a better job on access and we did a better job on timeliness in particular, then they would say, well, why would I even bother thinking about that boutique clinic? That's just crazy. I could spend that money on a golf club membership or something.
Right.
So how do we make the public system, in a sense, privatization proof? Because it's just good enough.
Right. Well, I mean, I don't actually completely agree with your conceptualization of the problem. It is completely true that people move to the private sector because they're desperate, but they also move to the private sector because there is one that is being made available. So that is part of the solution that one has to think about is how do we appropriately regulate that interface, right? So what's the appropriate balance between public and private, particularly when it comes to our workforce? So if we only have, X number of doctors, nurses, pharmacists, dentists, and so whatever, how do we make sure that if we want them working in the public system, at least some proportion, reasonable proportion of their time, how do we approach that? And if it's just like we have to pay them gazillions to be there, then that's not the greatest solution, right? That's the dynamic that you see between public and private in the US, and that's why the public system costs a fortune. Just a reminder to everybody that, they spend more public dollars per capita, and if you've been watching the pit, you will know why, than Canada does, right? So Medicare, Medicaid, and all the other things, they spend more tax dollars per head than Canada does, and they leave a lot more people uninsured. So, figure it out. It isn't just that they get a lot more because they don't actually have a lot more doctors and nurses than we do.
Right.
It's pretty similar. They just pay them more for the same thing. It's the grind of good.
But is there a big thing you would do? Like if you had like carte blanche, calling?
No.
Is there an...
It was all the stuff that we need to do.
Well, let's start with a small one. Let's start with a small one. So the people practicing in the $4,500 membership clinics, they also bill the public system. If we were Ottawa, would you say we're gonna fine you as a province under the Canada Health Act because you're charging for medically necessary services? Yes or no?
I think they are charging for medically necessary services, and so in theory, that should be you don't get fined, right? You get the money taken back from the province.
Yes.
This is an example of one that is probably quite clear cut, but there are other examples where people are, really desperately trying to get hold of primary care and it's virtual and so on. And so are we actually going to shut that down until we've done something to improve their access? I think that is a harder call.
So on that hard, boring work part, one of the parts of this is, again, using primary care as, I think the Sentinel example took place in plain sight over 20 years, expanding to 6 or 7 million people who don't have a regular source of care, which strikes me as extraordinary lack of interest, or you could call it negligence, in allowing this to happen. And it involves the collective agreement with physicians. It involves all those entitlements about you don't have to practice in the areas of need. You can all get a billing number and practice in the cities. Again, decades old conversations.
Decades and decades, yeah.
So why can't we fix something like that?
Well, I do think that you have to get the control of this out of government. So I do think it needs to go to some kind of arm's length agency, something that is in fact not just in control of the hospitals and home care, but is also in control of the docs. It's a big move and it will be resisted up the yin yang, and we've seen the cost and consequences of that. So you are going to have to really, a government brave enough to do that is going to have to really communicate the need for that.
We've had this experience though with, creation of arm's length agencies, then we pull back and then we introduce them
But they
again.
don't
Is it
control
really
positions.
is it really that we want it out of the hands of the government, or is it just the way that we budget?
But they don't run it from a minister's office, Dale, right? Ever. Name one.
Look, granted, but
They set targets and objectives and so on, but they devolve that to other entities. But you're right that they give them more responsibility, and in our case, it's the physicians that are really the big levers here. I think we can, when we think about comparisons with other jurisdictions, we often think about Australia, right? But the big difference is that the Commonwealth, which is the federal government, actually has direct jurisdiction, and Stephen knows this better than I, over doctors and drugs. So those are two of the biggest levers of expenditure. Being able to control how they behave and be able to, how you pay them and so on, is a big deal. Our federal government doesn't have that. And so we have this sort of, the split between the feds and the provinces. So that's a diluted accountability piece. And then at the provincial level, this kind of consistent sort of kind of bringing it back to the province, rather than saying, look, we're going to set up really good the agency. It's going to be hard, right? That we will wear some of this. We'll wear some of this at the polls. But if we can actually have a system where we are making more rational decisions across different areas of need, then we would, as you say, Dale, you're completely right. Like if you have the budget for the population, then you would make better decisions about what is covered and what is not.
But technically, they've tried to do that with Alberta Health Services and Ontario Health.
But not controlling the doctors, Dale.
And no accountability built into this. Everyone has lofty, good-sounding goals, right? But decide what you want. What are your performance indicators?
Step back.
You step back, exactly.
And have a negotiation about the budget. How much you need to actually achieve this? What is reasonable? Can you do it? Right? And it can't be everything, right? It's just got to be a few things that they're going to go and do. They're going to improve the system in certain ways. And you step back. I mean, it's actually not rocket science. That's the sad thing, right? And it's boring.
Well, it's not.
This next book is like boring health policy reform. Right? It's not very exciting. But the trouble is, all we do is come back to, well, the answer is not the boring stuff. The answer is privatization.
Yes.
Right? If only we could privatize, then it would all be rainbows and ponies. Or on the other side, more public, then it will all be rainbows and ponies as well. Neither is actually the answer. I support public generally because I think not because I'm that much of a bleeding liberal heart, but because of the economics of healthcare, right? Just how healthcare functions. It makes sense for most of it to be public.
Well, it has to be. If there's no cross-subsidization, the whole thing is a failure. I mean, the people who need it the most will die. So perhaps to oversimplify, where this really comes home to roost now as the litmus test for saving a public system is primary care. And as you said, the historical deal that we struck where the physicians are not fully in. They're contractors, they're independent, they secured that right. It courses through every medical union's negotiating stance, and they desperately want to preserve it. I'm not so sure young doctors care so much. Can we solve this problem in any way? Like if you just had a better, more accountable, fuller collective agreement that included some hard obligations, could you live with what we have now, where they're independent contractors, but some teeth with some collective responsibilities and maybe collective incentives? For example, you could say, look, we're not going to tell you how to serve the entire population, but if you don't get the number from 700,000 to 350,000 that don't have a regular source of care, we're knocking 20% off your billings or something like that. I mean,
I mean, how that actually happens again, we just come back to who's negotiating with them. And is that the right choices to make? I think that depends on a bunch of different things with, the other expenditures they might need to do, exactly what the call would be, Stephen. But it is to say, let us get this out of decision making from the minister's office. So I was talking with somebody the other day who had been in government, and I mentioned to them, the evidence that we've had for years up the yin yang about why you need sort of central triage systems to try to deal with wait lists. And I sort of said, so, when you had the power to do something and you saw this evidence, like, why didn't you do it? Right? I said, did you not think the evidence was real enough? Or no, agreed with the evidence, but that the feedback after consultation was that, a lot of doctors found that the long wait times were kind of like a retirement security plan for their own services, which shocked me. I didn't actually think that that was such a deal in Canada, but that was what so basically, I think this person was saying there was resistance from the physicians to a central triage system to make sure that we got wait times down. Now, that is a pretty straightforward thing to do. It doesn't seem like it would really interfere that much with the revenue generating potential for physicians. But even it seems like a whimper of discontent is enough to back governments out of doing good policy choices.
But it may actually affect the income, because if you allocate OR time based on how popular you are and how big your wait list is, which still happens in some places, it makes a big difference. There are instances, I can tell you an instance where in Regina, a new specialist wanted to come to town, and the existing short supply people said, no, we don't want them here. We want to preserve our very lucrative market.
Okay, so that's, well, then to the point, it's a problem, and that it doesn't seem much to us, but rational decision making. And, I think for both the people who support public Medicare and those who support privatization, surely that could be something we agreed on.
One would hope. Getting back to the national icon, the Canada Health Act. So you've got an hour with Mark Carney, and you talk about healthcare, and he says to you, so should we take a shot at redoing the Canada Health Act to make this thing work better for all those things we said? Yes or no? Would you spend a lot of time on that?
Oh, if I had a shot at it, I definitely would. And I would include some, aspects. So basically the Canada Health Act is waffly. And doesn't have a lot of teeth, except when it comes to paying out of pocket and private finance for medically necessary hospital and physician services. But on things like accessibility and, as you've mentioned, comprehensiveness, it doesn't actually say anything. It just says reasonable access, and that's not defined. So if I was Carney, I would be putting some teeth around what reasonable access actually means. I think it should include access to some kind of family healthcare team or provider. Everyone should have that opportunity for sure. And it should, try to have mechanisms in there to allow people to force provinces to articulate what reasonable access means for their province. So I'm not going to tell Newfoundland or I'm not going to tell BC what that means, but I will demand as the federal government that they actually have to articulate what that means. I think they should do that. And that allows them to be more resource sensitive, right? Like we can't afford to have ER wait times of 2 hours or less, but we can have this, right? And we will change that as we go along, but we will be transparent, it will be open, and we're accountable to our public for achieving that. And I don't think that messes too much with provincial authority. It's just saying, if you want our money, you actually have to say what accessible healthcare means for your province. I would do
So
that.
are you stopping short of conditionality? I mean, this has been a long history of failed attempts for the feds to make those transfer payments conditional, right? They will sign health
Yeah,
accords.
I would definitely make it conditional on you have to have a process for determining what is reasonable access.
The provinces may say, well, we can do that because we'll just say this is reasonable access, and then we don't measure it, and then there's no performance requirements.
You have to actually do it. You actually have to say to your public, this is what we're
They
saying.
start the conversation, is what you're saying.
Yeah. What is reasonable access? And I honestly think it's going to be hard for most provinces to say it doesn't include primary care. For example, it doesn't include life-saving drugs, so maybe you call me Pollyanna-ish, but I do believe in this sort of principle of transparency and procedural fairness, right? That this will rise us up. So if I was Connie, that's what I'd do.
Well,
It is still a little depressing that our system, like the best we can do is create a definition.
We have a loose kind of constitutional arrangement because we are a very diverse country. So we have to be quite careful about saying, I came from New Zealand, which is a very centralist kind of place, and you can just rule from the middle, but you're only like 5 million people, and it's quite relatively small. So, this is part of Canada, is the division of powers between the federal and provincial governments. It is what it is. But this is something that the feds could do and would help, I think, drive accountability through the system on a key indicator for us of accessibility where we're failing all over the place.
so what you're saying, which brings joy to my political scientist heart, use the bully pulpit more. Use it
Yeah,
more effectively.
normatively.
Normatively, exactly. Say this should happen,
Yeah.
and be
And,
prepared to deal with the argument. Well, we agree, but you have to give us more money, which is
great. And
normally the tactic, right? I mean, in the
well,
state of
it's okay
federalism.
if they need a bit more money, but like buy off, I would start with the provinces that want to play and work with them and say, okay, like let's do this together. Let's show the others.
Colleen, this has been a delight. Thank you so much for being with us. I think that everyone's going to have learned something here, and I think reframing the debate in a more useful direction has been a real service. So thank you again.
Well, it's lovely to see
Thank
you,
you.
Stephen. It's been too long. And lovely to see you, Dale, as well. So thanks for asking me to join the conversation.